Hi, good morning or good afternoon, everyone. Thank you for joining us today and welcome to today's webinar, Creating Safe Environments in Inpatient Settings. Next slide, please. This webinar is sponsored by the Northeast and Caribbean Mental Health Technology Transfer Center, or MHTTC, and we're housed at Rutgers School of Health Professions in the Department of Psychiatric Rehabilitation and Counseling Professions. My name is Kathy, and I'm the project coordinator of the center, and we'll be introducing our webinar speaker for today. The MHTC is funded by SAMHSA, the Substance Abuse and Mental Health Services Administration, to enhance the capacity of the behavioral health workforce to deliver evidence-based and promising practices to individuals with mental health conditions. We also address the full continuum of services spanning mental illness prevention, treatment, and recovery supports. And we also provide training-related workforces to police, first responders, primary care providers, vocational services, etc., to provide effective services to people with mental illnesses. We also utilize supplemental funding to support school teachers and staff to address student mental health. Next slide, please. As a reminder, all of our training programs featured on your screen, as well as products and services, are available to you at no cost. Next slide, please. If you're interested in staying up to date with the events and products that our center is offering and providing, please sign up to receive our email communications. You may do so by scanning the QR code provided on the screen, and I will also enter it in the chat box. Next slide. Following this webinar, you'll be asked to complete a brief survey. We value this feedback and use it to improve our activities and inform our future activities and programs. These surveys are also important because our continued funding is linked to their completion, so we thank you in advance for your participation. We also want to let you know that this webinar will be recorded and posted on our website within 7 days, along with the presenter slides, and you will also receive a certificate of completion within 7 days. Next slide, please. At the time of this presentation, Marian Delphin Rittman served as Acting Assistant Secretary for Mental Health and Substance Use at SAMHSA. The opinions expressed herein are the views of the speakers and do not reflect the official position of the Department of Health and Human Services or SAMHSA. No official support or endorsement of DHHS or SAMHSA for the opinions described in this presentation is intended or should be inferred. We encourage you to interact with our presenter during the webinar by using the chat feature. Please post any comments or questions you have in the chat, and I will collect your questions as we go and ask them of the presenter during the Q&A time towards the end of the presentation. During the webinar, our presenter may pose questions to you. Please use the chat feature to answer them. As a reminder, the MHTTC network is committed to using affirming, respectful, and recovery-oriented language in all activities and programs. Next slide, please. We also wanted to let you know that the new 3-digit dialing code for the Suicide and Crisis Lifeline is now available through 988. 988 is not just a suicide crisis line. It is for people experiencing a suicidal, mental health, or substance use crisis or any kind of emotional distress. It's also for people who are concerned about someone experiencing a crisis. You can connect by calling or texting 988, or you can chat online at 988lifeline.org. Calls, texts, or chats are responded to by a trained crisis counselor. Now let's begin our webinar. We have Ken Kinter with us today. Ken Kinter has worked with people with mental illness and addictions throughout his 30-year career. This includes 25 years working in psychiatric emergency settings, partial care programs, and in a county jail. He has worked for UMD and J. Rutgers for 16 years. His current faculty appointment is in 2 different projects, implementing evidence-based practices in psychiatric hospitals and implementing motivational interviewing at several New York, New Jersey service providers as part of the Mental Health Technology Transfer Center grant by SAMHSA. Ken is currently completing his EDD, and his dissertation involves predicting and preventing 30-day readmissions to state psychiatric hospitals. He has also published on lean thinking, Six Sigma, deinstitutionalization, wellness centers, and illness management and recovery. He and his wife also operated therapy practice in Bordentown, New Jersey, where he works primarily with people with addictions and with families of people with severe mental illness and addictions. Welcome again, and I will turn it over to Ken.
Thank you very much, Kathy, and thanks to all of you for showing up today. Again, this is sort of an interesting return for me because I worked in screening for many years and really enjoyed it. And now I've been working in the state hospitals where we were sending so many people from screening over all that time. And one of the interesting parts about today's topic is it's a topic that is it's applicable throughout the mental health system and to my experience specifically from seeing it in emergency room settings and also in the state hospital. And actually, it's our approach to both of those and both those areas have been pretty similar, but we'll get into that as we go. So what we're here to do today is to review literature on different types of inpatient aggression, because all aggression is not the same. We look at it, it all looks like one thing, but when you get into it, it has sort of a method all its own. And in order to prevent it, you have to study it. Identify contributors to inpatient aggression, and then to describe what we've been implementing at the state psychiatric hospitals, something called 3 Steps to Safety. And we've had some success with that, in increasing the amount of safety at the hospitals. And we'll talk about how we've done that. We get some time at the end, we'll talk more about the implementation piece of it, but we want to get the practice part across to you as well. And I'm hoping that there's a way that you'd be able to implement something like this where you work. And the other thing that we've discussed is that this doesn't need to be a standalone webinar. This is something that we can build upon and talk about more later on if you're looking to implement something like this. So let's start by talking about the problem. So the rates of injury that occur in all industries is 2 out of 10,000. And then you look down through healthcare, nursing, and then specifically psychiatry, 77.7 per 10,000. It's an astronomically high rate. And not only is it higher than other areas of healthcare, but then when you look at it compared to other industries, so in any given year, there's a 1 in 3 chance that a psychiatric staff member will be assaulted. The risk of injury is greater than injury rates from agriculture, mining, manufacturing, transportation, and construction combined. And so there's the frequency of violence, and then the other issue is the severity of violence. Many of these assaults are not physically damaging, but they do have other consequences. But I am sure that every one of you can tell a story about it, or have experienced yourself a severe injury, and that has a significant impact, particularly when it's coming from the place where you work, where you're trying to help people. So what are the effects of violence? Quite a few, both in terms of the physical damage that can be done and the emotional damage that gets done. People become afraid to come to work. Their morale is affected, productivity is affected, how you approach people is affected. People take additional time off. They either have to for medical reasons or for mental health reasons. Staff turnover. I've definitely seen where someone, as the result of an assault, has decided that they needed to change jobs. It negatively impacts patient care. People don't want to put themselves in a position where they may feel vulnerable, so they're acting in an understandable way to protect themselves, but at the same time, it reduces their effectiveness and paradoxically can increase the risk of the person being assaulted. Staff burnout, and I would throw compassion fatigue in there as well. And also PTSD among patients and staff. And I don't want to undersell that. The model of PTSD that I always discuss is that we all carry a backpack, and we have our backpack of trauma when we come in the door. And then as things happen, as we witness things or as we are involved in things, we put more and more things in that backpack, and it does accumulate over a period of time. The 2 hospitals that I spend my most time at now are Ancora Psychiatric Hospital and the Ancline Forensic Center. And I've noticed that the officers at the Ancline Forensic Center will not sit in a restaurant with their backs facing the door. They have to face the door wherever they are. And I've heard this with law enforcement as well. And I broached the subject with them. Is this something you did before you started working here? And they said, no. I'm like, does this sound like a PTSD symptom to you? I don't want to diagnose, but, you know, are there those symptoms that we all have based on what we've been involved in or witnessed? I imagine it's a whole lot more common than we think. So let's get into this diagnosing of violence to a certain degree, because if we treat all violence as if it's the same, then our intervention isn't going to be particularly effective. So 3 types of violence: instrumental, psychotic, and reactive. Instrumental violence is known as premeditated violence. It's violence with a plan. The person is using violence in some way to accomplish a goal. So an example of that might be if somebody makes a threat, they want to be put on a medication, and if they're not put on that medication, then they threaten some sort of consequence. In the state hospitals, what we see is, if you don't discharge me, then some sort of violence is going to happen. Or in an emergency room setting, if you don't let me go, I'm going to go off, something along those lines. 2 is psychotic violence, and this comes right out of the symptoms. Someone thinks that you were sent by the devil, that you mean them harm, something along those lines, and they are responding right out of those symptoms. So symptomatic violence. The 3rd type of violence is reactive violence. And we'll talk about the frequency of these. This is violence that happens immediately upon a person receiving bad news. And relating this back to my experience in screening, which admittedly now is a few years ago, but I don't know if this part has changed. For example, there were certain points that you could almost predict that a person was going to become violent in a screening setting. When they first came in and the locked door closes behind them and you start going through the, okay, we need you to close and all that kind of stuff. A second time would be if you were telling the person that they needed to stay for any period of time. You need to stay to see the psychiatrist, you need to stay overnight, something along those lines, or it's going to be a couple hours before you can be seen. And then the last one was if that person found out they were being hospitalized. After you had the discussion with them, that you either need to sign in or you may see the doctor about being signed in on an involuntary basis. You could almost predict when these things were going to happen. In fact, those were usually good times to call security before you got to these. My old boss, Jim Romer, used to call them kill zones. I've dialed it back a little bit. I call them hot zones. These are hot zones, areas where you can predict the capacity for violence is going to go up. So let's take a look at the frequency of these 3 things as they occur on an inpatient level. And I would love to see emergency settings compared to this. So if we take a look at this, the majority of violence that we see in both civil and forensic hospitals is reactive. So it's in that moment response. A person gets bad news. They're not going home when they want to go home. They see the judge and they get their time lengthened. They get bad news from their family, any bad news. This type of violence is almost more about where someone's coping skills become overwhelmed and they go off in the moment. And so the violence happens. And one of the ways that you identify reactive violence is 5 minutes after it happens, the person's sorry. Their intention was not to hurt somebody. They just did something in the moment. They lost control. And now here they are. And you see these, it's over half of the violence, and in civil hospitals, it's about 2/3 of the violence we face. The next one that's most common is the instrumental violence. And you might notice that there's more of this in a forensic setting than in a civil setting, but not as much as you might think. I think when people think of forensic hospitals, they think of people that are much more criminogenic behavior. And it resembles the civil actually a lot more than you would think. And then the one that we see the least of is probably one that people may have thought we've seen the most of, and that's psychotic violence. And I think that's because this one responds to medication the most, and in the inpatient setting, people are on medication. So this is probably why we see this the least, but you still get it. You still get people that have intractable psychotic symptoms, or they're not stable on medication yet. So there's still a not insignificant amount of psychotic violence that happens. So looking at Neiman's model, violence also comes from a combination of interactions. So you see this little pyramid here at the top. We have the service recipient, which, okay, in the hospitals, we've struggled a little bit. We are trying to get out of calling everybody a patient, even if they're in the hospital. Just like we try not to refer that the person lives in the hospital, they're only residing there temporarily. So service recipient, or SR as we call them, is sort of a synonym for patient. So one of the dimensions of inpatient violence is the patient themselves and different aspects of them. Another one is elements of the environment around them. Is it a loud environment? Is it a very crowded environment? Is it a chaotic environment? What is the emotional tone of that environment at this point in time? You know, are the staff angry? Has there just been an incident? Are there staff on that don't like each other, or staff that are very strict, things like that? But the environmental part is more the physical aspects of the environment. And then you have the staff themselves. Are they even fully staffed? Let's start from there. Or did somebody just get mandated into doing a double? Or is somebody working in a setting that they're not used to, somebody that's new? So you take all of these factors, and each of these domains, there are a lot of factors that contribute to them, but you put that in the mix together and you can develop a much more violence-friendly environment. So my colleague, Dr. Tom Bartholomew, did a lot of studying on inpatient violence, and he looked at a lot of the literature. And he did a literature search that went from 1976 to 2014, looking at behaviors that contribute to violence. And what he found was that the largest contributing feature to violence was controlling authoritarian staff, which is kind of interesting. Normally, how it normally works is if you ask the patients why a unit is violent, they blame the staff. If you ask the staff why a unit is violent, they blame the patients. Well, the literature broke it out like this. So you see controlling authoritarian staff as the thing that was the largest contributor. And then as you go down, you start to see some of these other things: poor communication, poor alliance between the staff and the patients, violations of rights, staff being angry, patient avoidance. That one's a pretty underrated one. If you leave people alone for a long time, you usually think you're giving them their space and it's developing safety, but it doesn't really work out that way. If staff are afraid or anxious, rules being applied inconsistently, and we could spend a lot of time on that one. In fact, I think that one applies well to screening as well. When you change from shift to shift, sometimes with the staff that are on, it changes your tone. And then blaming the patients for violence is one as well. Just one other point regarding the inconsistency of rules. And this is an anecdote from my own history, but I wonder if it's something that still applies. When I used to look at the schedule for the month going ahead of time to see what staff were going to be on with me for varying shifts. And I used to make judgments about what kind of shift I was going to have based on the staff that I was going to be on with. Now, this has nothing to do with the patients. We didn't know who the patients were going to be. We might have no patients. We might get slammed. Part of the beauty of emergency services, you never know what you're walking into. But if you looked at the staff, you might say, you know what, we've got really strict staff on today. That might be tough. We might end up having some problems because it's going to be really over-controlled. Or the opposite. What happens if you have someone on, in our case, it might be a charge nurse, that is really relaxed and maybe lets too much go. And then we're going to have shift change and it's going to change again. So if the evening shift, for example, which I worked most of my career in, was very relaxed, and then you get a very strict night shift nurse that comes in, the patient has to go through those changes. So 1 minute everything was relaxed and chill, and now it's very strict. With everything that they've got going on in crisis already, that's a recipe for violence right there. And neither group will see that coming regarding the staff. So I think that's an interesting point. I used to assess how tough my shift was going to be before the patients even got there. So gave me a little hint that there was something to this back then. I don't know if that's still the case. So in the inpatient setting, there are certain situations I described earlier about the experience in screening where you have those what Jim Romer used to call the kill zones, or I call the hot zones, which is where there are periods of time that are much more likely to promote violence. And these are situations on an inpatient setting, but I'm also guessing this applies to screening as well, uh, that um, these are more situational. So they're not based on timing, but they're situational. So, for example, limit setting, activity demands, and denial of requests. So whenever you're telling a client, don't do that, you can almost feel the level go up. You know, there's now more of a potential for violence than there was, because you're stopping that person from doing something that they're doing. The second one is activity demands, and that's when you're directing someone to, you're giving them an instruction. All right, you need to do this. Very often in an inpatient setting, it is the activity demand is programming. So we saw violence levels drop quite a bit during the COVID lockdown because a lot of the groups and a lot of treatment stopped. So people were sort of left to their own devices. And then when we started programming back up again, you started to see a lot more violence based on these activity demands and new activity demands. And the third hot zone here is a denial of request, which is when you're just saying to somebody, no, you can't use the phone. No, you can't have food. No, you can't do, you're not being teamed today. And it could be a little thing. It doesn't have to be a big thing. On night shift, one of the biggest things that we have is when people just don't have access to food. They want a snack in the middle of the night, and who among us has not done this? You know, you raid the fridge at a certain hour of the morning, and just because you're in the hospital doesn't mean that goes away. And a no can very often, a food request can turn into a violent situation. So these three situational triggers can be made worse by a big term called perceived procedural injustice. And what that big term really just means is that a person feels like they're being singled out. One of the things that really lights the match for violence is if a person feels like it doesn't have anything to do with the rules, it's just you exerting power over me. Psychiatrists, despite the fact that they actually don't spend a large proportion of time with service recipients, tend to get assaulted disproportionately high rates because they have power over that person. And when they exercise that power over that person, especially in an involuntary treatment setting, the person may respond, they may take this as personal, and then they may respond with violence. So as we're going to talk about going forward, the idea of consistency can't be overstated. Just having that everyone is viewed as being treated the same, because as soon as a person feels like they're going to be singled out, then violence becomes much more likely as a response. And I'm going to get into 3 steps to safety in a minute, but I want to talk about one other thing that we built into it when we were implementing this in the state hospitals. And we used the metaphor of a bank account. And I'll probably talk about this a little bit more when we get into validation. But so you think about what a bank account is, and you put money in the bank account, and that way when you withdraw money, it's covered. Well, we looked at the therapeutic relationship in a way as a bank account. And all of these steps that we took, particularly validation, we would, every time that you have an interaction with someone, you're putting money in that bank account. You know, every time you ask somebody how they're doing, or you call them by the name that they like to be preferred, or you have a good interaction with that person, or you meet a need that they have, you're putting money in that bank account. And then when you get to the point where you're in one of these situations where you will have to do limit setting, you'll have to do activity demand or deny a request, that's a withdrawal, or you're writing a check on that account. And if it bounces, if you don't have a relationship with that person, it's much more likely that that account will bounce. We found in the violence research that in addition to people exerting power, people were far more likely to assault staff that they did not like. And they were far less likely to assault people that they did like. So it speaks to the power of that, of developing that bank account. So your goal is that every day you're putting a little something in that bank account so that when you get into one of these situations, you have enough funds to cover it. I think we can probably all relate to both sides of that. We had a situation in the forensic hospital where there was a multiple person fight on one of the units. And so it's, we've got like WrestleMania going on the unit. And one of the officers there looked at one of the patients and just said to him very brusquely, go back in your room, go back in your room, just to get him away from it so he wouldn't get involved in it. And he turned around and went back in his room. And then after the situation was resolved, the patient took the officer aside and said, look, I just want to let you know, I don't like the way you talk to me. Like you just talked to me like I wasn't a person. But you know what? I know you were a good guy. I know there was something going on and, but I just needed to talk to you about that. Basically, what I took from that was this man complied because of the relationship he had with this officer. And he knew that if he had a problem with him, he was going to be able to talk to him about it later. And they worked it out and everything was good. What happens if this person doesn't know me and I go in there and I make that same statement to them in the same way? That person may have reacted and I may have made the situation worse. My last point on this is you probably have people in your life who, because of who they are to you and their relationship to you, can say anything to you. And even if you disagree with it vehemently, because of who they are, you're going to hear them out. So to me, that's a person that has that big bank account. Now, I don't have that big bank account with you. I can't say that same thing to you and have that same impact. In fact, if I said it, it might lead to something like violence or a confrontation. So the bank account piece, although not a specific part of 3 Steps to Safety, is really instrumental in making it work and just in terms of interactions altogether. So the 3 steps to safety themselves is validate, explain, and problem solve. Very simple, almost too simple. And there's a lot of things that complicate it. So we'll get into what those are. And the last point before I move into what each of these steps are, and they're in this order for a reason: validate, explain, and then problem solve. And we'll get into that as we go. So 1, validate. Convey understanding of a person's feelings and their point of view while normalizing them in the situation. Okay, that's a great definition. Let's talk about what validation really is. Validation is really about being present with that person and hearing them out. The way I put it with validation is, where is the point of what's going on with that person that you can relate to? In the terrible example I gave before, if a patient gets up at 3, 4 in the morning and they want something to eat, I am guessing we have all been there. We can all relate. Now, if our response is, there's no food now, there's nothing for you to eat, go back to bed, okay, that's one type of response. Another type of response might be, that, well, food is during these times. These are the only times that food is available. We went right into the no. But what happens if you start off with, yeah, man, I hear you, I get the munchies sometimes late at night too, or just something where you connect to where that person is. So how much can you put yourself in that person's shoes and, where they're coming from and share that with them, that this is a normal situation. There's enough going on where this person feels like they are doing something wrong or being punished already. And then to put all this stuff on top of it. So how would you feel in that situation? You're hungry. They say, no, you can't have any food. And then you're going to go through the rest of the night hungry until breakfast. Another important part about validation, and we really struggle with this in the state hospitals, and I don't know if you would have this struggle as well. There is some confusion about validation is not giving the person what they want. If a person wants to use the phone, you can let them use the phone while still invalidating them, or you can validate them without letting them use the phone. Validation is about communicating to that person as a person before we get into the professional roles in the situation that we're in. It's just human being to human being. Validating an emotion. I understand that you're frustrated. I get that you're angry. I hear that you're sad. I probably would feel sad in the same situation. It's before you get to any rule or policy or action, anything along those lines, really from a human being. So for example, for those of you below a certain age, that thing on the right is a payphone. And yes, we still have them in the state psychiatric hospitals. I don't see them too many other places though. So the example, John has been on his phone, on the phone with his mom for 30 minutes. Staff ask him to get off the phone because others are waiting to use it. He gets angry, yells at the staff, and slams the phone down. So if the first thing we say to him is, look, you got to get off the phone. It's been 30 minutes, get off the phone. We might be agitating John. We might be adding to a situation, and he may already be being agitated by what he's hearing over the phone. So we're in essence provoking him to a certain degree. Validation. I would be upset too if I couldn't talk to my family whenever I wanted. It must be hard to be away from them right now. You know, how much is that lifeline? Think of any of you who've been in medical hospitals before, you know, just another sort of environment. You're used to seeing your family and your loved ones all the time. Now there's certain hours when you can see them, or you talk to them on the phone, or, you know, it's complicated, and it adds to the frustration of the situation that you're already in. And this is before we talk about mental illness or anything like that. So let's just do a quick test on this about validation. You ask a patient to take her medication. She refuses, saying, I'm busy. She's watching TV. When you tell her that she doesn't look very busy, she crosses her arms and says she will call the CEO and the patient advocate to report you, and her voice starts to go up. Which example is the best validation response? And A, we have come to the med window right now, a command. B, you can watch TV later after you take your meds. C, I can tell you're upset right now because you prefer to watch TV. I would feel upset too if someone interrupted me doing something I enjoy. Hopefully this one's pretty easy. C is validating, because we're starting by validating that person's emotion. I get it. And I think at the heart of validation is communicating that I get it. I want to pause for a second just to take any questions. I saw a few things come in the chat, so I just wanted to check in before we get to the end. If there was any questions about anything we've covered so far, and then I'll continue on with the 6 levels of validation.
No questions in the chat at this moment. Thank you.
Okay. All right, cool. So from Marsha Linehan, she delineated the 6 levels of validation. And this is something, if we were going to meet and talk and continue on this, this would probably be something we would spend a lot of time on, because this is what we actually struggled with the most, implementing this in the state hospitals. So the first level of validation is just being present. So let's think about how hard that is all by itself. Just being present and being in the moment, especially in a chaotic setting. It's hard enough to be present anywhere, driving in your car, even in your own home. But now let's take an environment such as an inpatient setting or an emergency room, and you've got all sorts of stimulation going on around you, all sorts of sounds, all sorts of noises, all sorts of smells, as I remember. It's really just hard to stay focused. And then one of the other challenges is you might feel like you're we always joke that you felt like you were a fireman because you're just running around putting out one fire after another. And unfortunately, the stress that you feel going from one situation to the next, you're still carrying the old one as you go into the next one. You very often don't have the opportunity to separate yourself from one setting before you go in the other, and you're not really focused on it. So there's some carryover, and unfortunately the carryover can make you less effective in this next setting. So to me, level 1 is really epitomized by just being able to stop and take one breath. You can take one conscious breath from one situation to the next. Then you can come at that situation better, and you're not bringing your own stress and your own agita from the situation you were just in to the next one. And of course, that's cumulative. There's a nurse at Ancora she's really hilarious. She's a great nurse. She always feels compelled. She's a nursing supervisor, and she always feels compelled to answer any phone call on the first ring. And you can see that she's still tense from the last call when she picks up the next call. And she gets progressively more agitated during the day. And I saw this happening to her. And I said, do me a favor, don't answer the phone until the third ring. And what you do before that third ring is just take one breath. Just take one breath, put whatever you were thinking of aside, and get yourself ready for this phone call. And just give yourself that couple second break so you can be up to 100%. She really struggled with it. So I kept trying to do things with her, like, is there something that you can think of? Is there like an island, a tropical island scene that you can think of, or a peaceful place in the woods? Is there someplace? I kept trying to do this imagery with her, and I was getting nowhere. And I said, what makes you happy? What when you think about makes you happy? And she said, Denzel Washington. And I went, okay, we can work with this. So take a breath and just picture Denzel Washington's face. Just picture it. That actually got somewhere. So that worked. So we used Denzel Washington to make her be more present for other people around her. So that's level one, is just being where you are. And it sounds so simple, and it is so difficult at all times. Level two, accurate reflection, being able to reflect back to people what they're saying to you, just letting them know that you got it. I get it. I understand what's going on with you. Level three, articulating nonverbal emotions, thoughts, and actions, being able to catch what that person is going through without them even having to say it. Level four, being able to describe behavior in terms of their history and biology, being able to explain to someone, look, I understand that this worked for you. In the past, how you got what you wanted was by throwing chairs and by threatening people. Or you feel like people are ignoring you, so you feel like you have to do something to get people to pay attention to you. There's another way. Or explaining that, hey, this is something that comes with the illness. Sometimes you're going to hear voices that tell you to hurt people. That's the symptom. A lot of people have it. So you can put it in the greater context. Level five, normalizing or recognizing emotional reactions anyone would have. Again, we're just trying to normalize it. People with mental illness respond to stress. They respond to anxiety and in their own way. And how do we normalize that and say, look, I understand this. This is not unusual. It's not just you. And then level six, now this one, I'm not advocating this one in the setting where you guys are at, but we're just giving you the whole picture of these levels. Displaying radical genuineness, just being who you are. I'm not recommending that you necessarily hug people during signs of stress or grief in the unit where you are. There are certain settings where that might be appropriate. There's certain settings where that isn't appropriate. But the idea of validation starts with you just being present in your own skin and then being able to relate to the people around you. Because otherwise, we get caught up so much in our own stuff that we just can't be there for someone else. So validation practice, a patient has to go to the store but doesn't have a level of supervision to go without staff. Staff tells him he's not allowed to leave the unit by himself and therefore cannot go. Let's see how we're doing on practice. I'm going to watch the time here because I want to make sure I get through all of this. So I'm actually going to keep it moving. And the bank account we talked about already. So validation is probably the hardest of the three steps to teach because it gets skipped. Usually what happens in inpatient settings, and I wonder if this relates to you as well, usually when we're telling somebody what they need to do or what they need to stop doing, we explain it in terms of policies and procedures and rules. We go right to that. So we go right to the professional thing and not so much about what's going on with the person. So we go, explaining the reason is explaining why we need to set the limit, make an activity demand, or deny a request. It's not personal. We don't have enough escorts. It's a hospital policy. I would get fired if I let you do ... which in screening was all about smoking. If you remember back in the day, that was like the whole thing. Smoking was all powerful. So on one hand, the patient probably feels like this doesn't have anything to do with them. I don't care if you don't have enough escorts. I don't care what the hospital policy is. I need to smoke. I want to go somewhere. I want to do this. And you're giving me some BS reason why I can't. And again, that validation hasn't been there. This is where that confrontation starts. And if the person feels like the staff is just making excuses, now we're in that personal piece, which is the express lane to things getting violent. So let's go back to the example with John on the phone. So we mentioned the validation part about saying, hey, look, I get that it's frustrating. You know, you're used to being able to talk to your family whenever you want to, and now you're on a time limit. But you can understand there are other people that want to use the phone and they want to contact their family too. So here's the explanation. I'm asking you to get off the phone because you've been on for a long time and we have a 15-minute limit. Other people are waiting to use the phone too, and they want to talk to their families. So here's an explanation. And it's not an explanation as blunt as 15-minute limit on the phone. You've already been on the phone too long already. You can already think about other ways that you could explain this. Or the timeless classic where they just shut off the phone from the nurse's station and person gets cut off part of the way through. So there are lots of ways that we can do this to actually attenuate or increase the possibility of violence. So for explain, test yourself. You ask a patient to take her medication, same scenario we were talking about before. Which is the best explanation response? Patients have to take their medications at certain times. Those are the rules, and I will get fired if they don't follow them. I understand you don't want to watch TV right now, but the nurse will only be there for a few minutes, and I don't want you to miss the opportunity to get your meds on your own. Or option C, you have two choices: get up or you will get a shot. I'm guessing that C probably sounds very familiar to a lot of people. I've heard it a lot of times myself. But the answer we're looking for is B. You're connoting understanding. You're saying, look, this is just a few minutes, and you're actually taking the side of the patient instead of putting yourself in a position of opposition to. So next up is problem solving. And the reason that we struggle with this one is because we tend not to spend a lot of time on it. Usually it's about we are the messengers and enforcers of the rules, and that's kind of it. How do we help the person cope with what's going on in the moment? They're obviously being triggered by something. They're reacting to something that's going on around them. How can we help them with this? And now that they've received this explanation, how can we help them process it? What can you do to deal with being upset? How can we help get you what you want? And also, how do we prevent things from going to bad places where they've gone to before? So let's get back to that example of John on the phone again. So he gets angry and slams the phone down. Problem solved one. You can use the phone again later when there's no one else waiting. You can call your mom back in a little bit. Problem solved number two. What would you like to do in the meantime while you're waiting? Would you like to go to the dining room for some tea or go out for some fresh air? Problem solved number three. What can you do to deal with being upset right now? Oops, cut that over. So the goal here with problem solving is you want to become part of the solution. How can you help this person with this next step? Instead of saying, no, you have to do this or whatever it is, and then walking away or waiting for that response, then what's the next thing that you can do? How can you help them solve it? And you have a couple different options here that, that people can do. And the more, the better. You want to put out a list of good options that person can take and then let them select one and then help support it from there. So going back to our example of the person taking her medication, she's busy, she folds her arms, she's going to report you to the CEO and the patient advocate. What are the best problem solving responses? A, you're supposed to come and take your meds right now. B, I'll let the nurse know you are coming so you can get things ready. So can you come during the next commercial break? C, if you don't come now, I'm going to report you to the treatment team. And we're going to take a wild guess here that it is in fact B. And again, your whole thing here is instead of being in opposition to the person, that you're kind of coming alongside with them. Part of this is compromise and part of this is facilitation. I can tell you on the inpatient units that I work on, one of the biggest problems that people have is they're waiting. They're waiting to see their social worker. They're waiting to see the psychologist. They're waiting to see the team. And the direct care staff are usually in the uncomfortable position of going back and forth between the two. If the direct care staff say, no, you're not going to be seen, that can be a violence promoting situation. So usually what their goals at that point is, if they can say, look, I'm going to go check in, I'm going to go make a call, I'm going to take a step to try to help carry the solution out, that goes a really long way. That puts money in the bank account, and that helps prevent violence. The last thing that I want to say before I get into this, the 3 steps observation tool, is one of the things that we found out in our own analysis of violence was that there were a lot of things that we did in the hospitals that actually promoted violence, and we didn't know it. And by looking at the trends in violence, we found some of those things. So, for example, one was we would have every patient on the unit stand in a med line together. So we would have 20 or 30 patients all in a line together waiting for their meds, and some of them had to wait a long time. And there would be fights in the med line. And so, of course, you could say, oh, well, the patients are fighting this and another. Well, why were 20 or 30 people waiting in this long line? Did we have to do it that way? Or could we just call 5 people up at a time, take care of those 5, and then the next 5, and then the next 5? There were places where we were sort of our own worst enemy in terms of promoting violence, either through the environment or even things like moving around staff. So people don't work with the same staff day in, day out. People get pulled and they get moved all over the hospitals. There are all these factors. So the easiest things to fix from the violence prevention standpoint were, what are the things that we sort of created, the iatrogenic causes of violence, and we could address those first. Shorter med lines was one. There were just a lot of things that we could do. And in your own setting, I'm sure there are things, and it can be everything. It could be anything from acoustics in the environment to consistency of staff to things like the med line or what time things happen. One unit in our hospital did something every day. They did a morning meeting first off, and they explained to the patient population on the unit all the activities that were going to happen that day. And if someone was out, or if there's going to be any changes, they knew about it first thing in the morning. So by 9:30 in the morning, everybody knew who was going to be teamed. They knew what the activities were going to be that day. If there was anybody absent or anybody covering, they knew about it. So there was no questions or confusion among the patient population about what their day was going to look like. Am I going to see the team today? Am I going to see the doctor today? Is my social worker in? All these questions were answered at the gate. And what had been one of the most violent units in the hospital became much less violent because everybody kind of knew what they were doing. So when we implemented 3 steps at the state hospitals, and we'll talk about this and some of the other things that we've implemented at the hospitals next, we did something, we created a 3 steps observation tool. And what we wanted to do was we wanted to have, in our hospital, was nursing supervisors supervise the interactions that their staff were having with the patients to assess how they were doing with these things. So if you see here under 1, 2, and 3, we had validate, explain, and problem solve. And in any given interaction, the supervisor would watch the staff and make this little 3-score scale about how their interaction was with the patient. So if the score was 1, if we're looking under validate now, 1, the staff was invalidating. They either ignored the patient or told them you shouldn't think that way or shouldn't feel that way. 2 was sort of the in the middle response, which was they were kind, they were nice, but there was no specific validation. And that's not bad, but there's room for improvement. And then 3 was that the staff validated the patient's thoughts and feelings. And then you would give them a score based on that. And if the score wasn't 3, you could say, okay, well, look, you were nice to the person and you listened to them, but what would have been a validation you could have used? Or when you said this to the patient, you actually invalidated them. You just told them they couldn't talk to their family, on this shift, and that didn't work. Explaining why, if they're explaining why there's an activity demand, a limit set, or a denial of a request, again, 1 would be the least desirable response. Staff did not explain why. It's the, kind of because I said so. Staff explained incorrectly or incompletely was number 2, and staff explained why, and that was for a score of 3. Problem solving. helping the patient decide what to do to deal with the situation, are all for choices. One was the staff did not problem solve with the patient. Two was they tried to solve by directing the person and telling them what to do or some other ineffective means. And three was where there was some interaction. The staff provided options. That's what I always look for in problem solving. You give them a list of good options and let them pick between one of the good options instead of going to a default bad option. And number four, it's cut off here, but one of the other things that we kind of lumped in here with 3 steps was the nonverbal communication. And that was that how you were saying what you were saying was every bit as important as what you were saying. In fact, it's actually more important. So was the person really expressing empathy for that person, validating that person? Were they really coming at that person in a compassionate way? Or was it kind of, the arms folded, looking at their watch, all of those little messages that get sent out to you that let the person know that they really don't care about you in not so many words. So we use those score sheets to kind of get people started and to use it as a supervision tool so that the nursing supervisors could help improve the interactions that their staff were having with the patients. So the project that I work for, just in terms of wrapping up here, and then we'll go to questions. These are some of the things that we've been implementing at the state hospitals. And IPR was the Inpatient Psychiatric Rehabilitation Institute that we are working for. And basically what we're doing is we are implementing all these things in the state psychiatric hospitals to try to make them safer places, because violence is still a very big issue there. For example, the aggression assessment tool training, we've been experimenting with using something called the BROSET or the DASA, and I have some videos about those on my YouTube channel and on our website that's listed in the bottom right corner here, a bunch of free trainings there. Recently, the civil hospitals have gotten, I don't know if you guys know this, the civil hospitals have all gotten medical security officers, or MSOs. Those were the types of staff that were previously only working in the forensic hospitals. And now we have them in the civil hospitals as well, but they don't do the majority of the hands-on interaction. They respond when there are crises. Ancillary response team training, there are also units in each building that respond to units when there are violence to try to help back up the unit staff themselves. And they get additional training on how to validate, basically how to prevent violence and how to de-escalate. That's really what a lot of that is about. And what we find is that there are certain populations that we have much more of an issue with. We have a lot of people with intellectual disabilities and a lot of people that have been in the hospital for a long time. And the violence level is actually much higher there than it is in, say, the forensic building or the admissions units, which was a surprise for those of us looking at the data. Technical consultation on specialized units. Again, these units that may have intellectually disabled people on them, or people that have been really resistant to discharge. How do we do more specific interventions and match interventions to those units' needs? Technical support of implementation for best practice programming. We really want to bring more research-based treatment to the hospitals instead of what has always been done. State hospitals are very set in their ways, and it's very difficult to move things forward in terms of treatment. And just because something works somewhere else doesn't mean it's going to work in a state hospital, or you may need to change it somewhat so that it works in the hospital. Illness management and recovery is a great example of that. A big thing that we're very excited about now is we are beginning to assess all patients coming into the state hospitals for trauma. And we do offer trauma treatment in all the hospitals. There are groups such as Managing Difficult Life Experiences, or MDLE, and something called TAMAR, because what we're finding out is trauma is about 80 to 90% of what we do. As much as many mental illnesses are biological, trauma plays a huge role in brain development, and of course, triggering people into things like violence. So we're kind of working our way back after ignoring trauma for very many years. I don't think we even used the T word in the hospitals until around 2014 or 2015. And now it's becoming much more common parlance. And I'm guessing that that's probably the same in other settings as well. And the last thing that we're very involved in, I'm going to be involved in this in Ancora very much, is restraint reduction initiatives. We're finding out that about 10% of the people that we serve in the hospital are 90% of the restraints. Those people don't do very well out of the hospital. They come back to the hospital. And what we're finding out is that the long-term consequences of the restraint may actually be worse than what they were actually doing in the first place. For example, we were restraining people, women are restrained disproportionately high levels, and also people are restrained for self-injurious behavior. And again, we're physically restraining a lot of people who've already been the victims of violence or sexual violence. And, you can already see how that might not be such a great way for us to go. So that is a high priority. How can we exercise these least restrictive alternatives so that we don't get into things like physical restraint? There is a lot more than the stuff that I talked about on this website. We have a lot of free online trainings that you're free to access. Every month we have a prep webinar where we have someone from the hospitals or from the mental health system talk about what they do and new things that they're doing. So very often in the system, it's so big that one hand doesn't know what the other one is doing. And this is an effort to put all that stuff together so everybody knows where everybody is. And we're also working on continuing to provide more training and education in an online format. COVID sort of made this mandatory for us so that we can continue to raise the educational bar for people that are working in facilities like this. And with that, I'm going to shut up and see if there are any questions or anything from all of you. I've been talking too much.
Thank you, Ken, for providing us with a wonderful webinar on this topic. At this time, we invite participants to share their questions in the chat box. I do see a couple of questions regarding the resources. Yes, this webinar is being recorded and will be posted on our website within 7 days, as well as the slides, and everyone will receive a certificate of completion within 7 days. Just looking here at the chat box to see if I missed any questions. Just wanted to see if anyone had a moment to share. Even if it's a comment, please share your feedback with us. So maybe someone's typing it into the chat box. Could you move to the next slide, please?
Mm-hmm. Oh yeah, so these are the references and the materials that this presentation was derived from, specifically a lot of the statistics that Dr. Bartholomew put down in here. If you have any questions about any of these or any of the other materials that we've used, or we also have an example of that 3-step score sheet. If you wanted to, I can send you a version of that so that you can use that.
Thank you. We want to thank you for joining us today for this wonderful webinar. If you could please take a moment to complete a brief survey. I shared the link in the chat box if that's easier for you, or you may also scan the QR code that you see on the screen. It'll take you to our evaluation survey. Next slide, please. Also, we want to share with you that we have a podcast channel toward wellness and recovery, and we are currently featuring Flourishing at Work, a plan for helping professionals, such as the professionals that work in these inpatient settings that we spoke about today. You can find it wherever you find your podcast, Spotify, Apple Music, or Podbean. And also, if you need to contact us, our email, I shared our general email in the chat box. It is northeastcaribbean@mhttcnetwork.org. And if you missed any of our previous webinars, you may access them through the products and resources catalog on our website. You may access them by clicking on the scanning the QR code that you see on your screen. Next slide, please. Next slide. Again, thank you for joining us today. And you may also follow us on our several social media channels. We have Facebook, Twitter, and LinkedIn accounts, and our website, mhttcnetwork.org. It will automatically redirect you to the center that is near you based on location. And our email is northeastcaribbean@mhttcnetwork.org. So thank you so much, Ken, again, and thank you all for participating today. We hope you have a wonderful rest of your day. Thank you.